thank you first for inviting me to speak. I'm Dr. Sahota, Amandeep Sahota. I'm one of the infectious diseases consultants. I think the remit of this was to basically go through a topic that's relevant to ITU, a common infection that you all, I'm sure, will have had lots of experience with dealing with. I found it quite helpful to, I've done this presentation before, and I found it quite helpful to go through essentially what are common CNS infection scenarios that we all have either faced before or will surely face very soon, either coming through ED, AMU, ITU, and just seeing if we're aware of the some of the detail of some very common infections. Are we okay with the guidance? Are we following the guidance in UHL? So I thought that would be quite useful to go through. So nothing that you'll see here is going to be out of the ordinary, some sort of weird and wonderful infection, but I think it will bring in some questions, hopefully. So I'm going to see if you can, if we can do some question answering. So those of you who've got a smartphone, would you mind logging into this website there, socrative.com, smartphone, tablet, whatever you might have. Hopefully it will work. And we'll get a few of you on there. So you log in on that website, you put in student login, it will ask you for a room name. So just put in that code. It'll have this on the next few slides as well. So hopefully that's starting for some of you. So you can answer questions as you go along, and we'll share the results as we go along as well. So the objectives are to go through some common scenarios, common infections that I consider to be common CNS infections. We'll go through at the end some of the UHL and the national guidelines of CNS infection management, and also discuss how good are we here at UHL at managing CNS infections according to those guidelines. If I show you the celebrities again, so hopefully you'll recognize all of these people. Now let's see if I can toggle. Okay. So this should bring you on to the first question. Which infection involving the CNS do these celebs have in common? Is it herpes simplex, Lyme disease, malaria, simian herpes B, or syphilis? Now I'm going to do some toggling. I hope this doesn't ruin everything, but I'm going to try and toggle again and see what you can see this time. Can you see a screen with questions and answers on it by any chance? You can't, can you? I'm making this too complicated for Teams. Can you still see my original slide?
Yes.
Okay. Now let me see if I can. Yeah, no, don't worry about the software. I think I'm going to make it too complicated if I end up toggling too much. Okay, so you can shout out or put in the chat or whatever. Any idea, anybody?
Herpes simplex?
No.
Lyme disease.
No.
Malaria.
Malaria. So which of these? They all had malaria, actually. So Cheryl Cole very famously had malaria. I think it was about 2010-11. She'd come back from a trip to Tanzania, and she became very sick on a photo shoot and actually ended up in an ITU down in London. It might have been the Royal Free. So she was really sick with it. And I know that you guys have seen some sort of good going cases of malaria, and I think there was a good case of cerebral malaria recently, who you might remember. And the unusual thing about that was he wasn't really waking up, and we did wonder if there were other pathogens, other infections perhaps going on. But I think the ultimate outcome was that he had quite significant sort of microvascular disease there. But yeah, so cerebral malaria. This was just to make sure that this Socrative was working. But don't worry, I'm not going to use it. We can just shout out answers as we go through. Okay, so the first case is a 70-year-old lady who presented to A&E and then to AMU. She lives with a family. She's normally independent. She's got type 2 diabetes, diet controlled, and hypertension as her only background medical history. She presented with a fairly acute history of gradual onset confusion over 2 days, having previously been well, a day's worth of fever, and also complaining of mild headache. She then became more lethargic, and the family were finding that she was much more difficult to mobilize. She had complained of a dry cough for a couple of days before that. There was no obvious photophobia, neck stiffness or rash noted, no weight loss, and no recent travel or unwell contacts. So on examination in AME, she did look quite unwell and was drowsy, so probably GCS was about 13. She was febrile, those were her OBS. GCS was 14, sorry, no neck stiffness, and no obvious focal neurology. She got the obligatory stat dose of meropenem in A&E, which was a few hours prior to her transfer to AMU. CT head had been done there. There was nothing on it, really. Chest X-ray also looked normal, and those were her blood tests. So slightly low sodium, microcytic anemia, high white cells, high neutrophils, slightly low platelets, and raised INR, CRP of over 200, and a lactate of 2.2, and some blood cultures had been taken, thankfully, before antibiotics. So a lumbar puncture was done appropriately. This showed hazy fluid, and no opening pressure was measured. Red cells quite high, was a little bit traumatic. White cells were almost 8,000, 87% polymorphs or neutrophils, 13% lymphocytes. The glucose was 2. No serum, paired serum glucose was done at the time. Protein of 3.66. No organisms were seen on gram stain. Xanthochromia, for what it was worth, was done as well, and that was negative. Some of the bits, so she's on amlodipine and bendrafluozide normally, no known drug allergies. So my next couple of questions are, what treatment would you give at this point? Out of those, what are we going to do next? Change to ceftriaxone and amoxicillin, or ceftriaxone and acyclovir, or all three with amoxicillin, or continue the meropenem, but think about changing to the CNS dose of 2 grams at TDS, plus acyclovir plus amoxicillin, or just continue meropenem with amoxicillin. So these are all potentially things that might happen in ED and AMU, to be fair. And I've seen various combinations of various drugs being given. Would anyone like to sort of suggest anything here? Again, this is why I did have the anonymous answering before, but I don't think it will work.
We would usually do D probably on ITU.
Yeah, so meropenem, acyclovir, amoxicillin. Any particular reason?
It covers pretty much everything and gets out of a hole.
Yeah, it does. You're right. And I guess part of this talk is thinking about what the everything might be in a specific situation. So when you're considering, I don't know, picking on you now. So when you're thinking about the organisms, what do you think is most likely in this situation? I guess is the key question. That we're hoping that that combo will cover.
I've forgotten all of the history, but I guess you're aiming for any meningitis causes. So
yeah, so we've got an acute history, of a febrile illness with CNS disturbance, and an elderly person normally well.
Yeah, you need to cover. Oh, I've forgotten. I haven't done it for too long. But you need amoxicillin for them as well.
Yeah. So the concern might be for listeria, and that's what the amoxicillin is for. We've got ceftriaxone. We know that's sort of the standard, isn't it, normally for CNS infection. And the reason that's there is because of covering strep pneumoniae and meningococcal disease, so Neisseria meningitidis. But we've also got acyclovir potentially for HSV encephalitis. Now I can't see the chat while I'm sharing, unfortunately, unless I'm doing something wrong here.
Nobody said anything.
Nobody said. Okay, so I just heard a beeping. Okay, so
that was somebody joining. That was all.
Fine. Now, if well, let's go to the next part of this question. So again, second part of the treatment, what would you give here? Would you give dexamethasone, 10 milligrams? Would you give it 12 hours after the dose of the first antibiotic? Would you give it only if bacterial meningitis was confirmed, by microbiology? Would you give it straight away, or would you not give it at all, as the first dose of antibiotics was given 6 hours ago? Or would you not give it because it's not indicated?
Straight away.
I missed that. Straight away. Someone said straight away. Okay, good. There's a few options there. We'll when I go through to the answers, we'll hopefully this will be clarified. Okay. So the question about what treatment will you give? So here, I think looking at that lumbar puncture, does that fit more with a bacterial or a viral picture?
bacteria?
Yeah, I think it definitely does, actually. So you've got predominant neutrophils, you've got a really high white cell count. We don't have the blood glucose to compare, but that is a low glucose. So, assuming she's 5 to 6, obviously got diabetes, that's sort of less than 50%, maybe bordering on a third. And that protein, normal protein, is about 0.5 grams per litre. That's also very high. And then on top of that, you've got your very high CRP. You've got more of a bacterial picture from the clinical picture here as well, and the other biochemistry. So I would be very what we're using very cyclically. We're using it to cover HSV and encephalitis, but that is not the CSF of somebody who has HSV infection. So I'd be quite happy to just skip that altogether. Then the reason we're thinking about amoxicillin is we want to cover listeria. So we'll talk about listeria a bit later. So listeria, there is a risk of that in people who are immunosuppressed or over the age of 60. Some guidelines say 55. So listeria is of concern here. So we want to make sure we're covering bacterial meningitis, so the common infections being pneumococcal, strep pneumoniae, and Neisseria meningitidis, but also listeria. So here, ceftriaxone and amoxicillin is fine. You could carry on with meropenem. So meropenem, it is good. It has it has good CNS penetration. It does cover both of those bacterial organisms, and it covers listeria. So the only reason E is wrong is that you wouldn't need the extra amoxicillin if you're giving CNS dose of meropenem, because you're already covering for listeria there. So I hope that makes sense. So I would be happy with A and not even bother with acyclovir at this stage. And we'll talk about steroids. Dexamethasone it is okay to give that, and you can give that straight away. And that's because the antibiotics were given, the first dose was given within the last 12 hours. And I'll talk about the guidance for dexamethasone use. So going on, she is given ceftriaxone. At this point in AMU, the situation was she wasn't given amoxicillin, so just ceftriaxone with steroids were commenced. And actually, fevers and confusion reduced within 24 hours. The CSF is culture negative. There's some hidden microbiology test which says it's latex positive, which I don't expect you necessarily to know what that means, but that is a bit of a clue to what we're seeing here. So would anyone like to hazard a guess at what this gram stain is showing? So these are, I'll give you a hint that these are sort of more dark purple looking.
Yeah, we've lost the slide.
Ah, sorry, hang on. See if I can get you back. Can you see this now? Can you see this okay?
Yeah, it's back.
Okay, sure. So this is, there's a gram stain here. Would anyone like to sort of try and hazard a guess what these are, what this organism might be? If I go to, there was a list of organisms where they've gone from this presentation for some reason. One minute.
It's cocci and then in chains.
Yeah, they were gram-positive cocci. So these are strep pneumoniae, most likely. Okay, and I'm going to bring you back to. I think you might have lost the screen again. So based on that, which do you think is true here? Close contacts need chemoprophylaxis. We need to change the antimicrobials. The patient needs to go into a side room with barrier nursing. You need to notify PHE or possibly none of the above. So with this, this is strep pneumoniae. So in terms of chemoprophylaxis, actually the chemoprophylaxis isn't needed for strep pneumoniae. It's really only needed for Neisseria meningitidis. So that is fairly infectious, particularly at the point where it's invasive infection. But strep pneumonia, although it also lives in the pharynx, is not infectious really to other people. It tends to get into the CNS through sort of bacteremia and then crossing the blood-brain barrier, or from defects in the inner ear, sometimes from basal skull fractures, head trauma. So it's actually not infectious in the same way that Neisseria meningitidis is. So actually chemoprophylaxis isn't needed. There wouldn't really be any need to change the antimicrobials at this point. You've confirmed the identity of the organism. We know it's sensitive in most cases to ceftriaxone, so I would carry that on. Again, the side room with the barrier nursing, so we know that there is the protocol for doing this for acute bacterial meningitis, but that is really only for Neisseria meningitidis, and that's for 48 hours. In this case, where you've pretty much proven that this is strep pneumoniae, you wouldn't need to do that. You do need to notify PHE, public health, well, whatever it's called nowadays, for the fact that this is an acute bacterial meningitis. They'd be less interested once they know that this is strep pneumoniae, because as I said, again, chemoprophylaxis isn't needed for strep pneumoniae. But usually the lab will notify of any acute bacterial meningitis. If you happen to be the first people, let's say you've taken someone straight from from A&E straight to ITU, and you think the diagnosis is acute bacterial meningitis, but it's not been identified yet, potentially you as ITU, the team may have to notify PHE until further results are known. So you may be the first people who do that. So she comes onto my ward in IDU. The blood culture shows that it is strep pneumoniae, which is penicillin sensitive, so that's fine. Potentially you could even use benzyl penicillin here and not ceftriaxone, but we do carry on ceftriaxone because it's got very good penetration into the blood-brain barrier. The CSF pneumococcal PCR comes back positive. So the PCR testing for both pneumococcal disease and meningococcal disease is actually quite helpful. A negative test doesn't exclude the infection, but a positive test is very specific. So if you're concerned or you think you haven't managed to grow the infection, I would check for both of those PCRs in the blood and in the CSF, because they can be really helpful. So that confirms really that this was streptococcal, invasive streptococcal pneumoniae infection with bacteremia and meningitis. So day 4 of treatment, dexamethasone is stopped as you would, and she's improving really well. But actually after a few days, she starts to spike temperatures again. There's an increase in the headache, and she's seeming to have some vacant episodes noted by the nursing staff as well, which she wasn't having before. So you go back and examine her again. Her GCS is 15. There's no focal neurology, no meningism. There's a soft ejection systolic murmur in the aortic area, but the chest is clear. And you do notice actually she's now got some new cold sores essentially around her mouth, but the rest of the examination is unremarkable. So improved, you think you've got the organism right, but then a little bit of deterioration. So what would you do next? Would you add in IVA cyclovir? Because you're now worried about the HSV infection from the cold sores? Would you do an MRI brain, and why? Would you repeat the lumbar puncture to see if something has gotten worse? Perhaps the infection has gotten worse. Maybe there is some resistance. You switch to another antibiotic like vancomycin, or would you do a transthoracic echo because you heard that murmur?
Would you want an MRI brain to exclude cerebral abscess just in view of the lower GCF?
Absolutely. So that is what I would be concerned about. So particularly with quite significant meningitis and invasive disease, These scans may not show anything, but it can develop into either cerebritis or potentially a cerebral abscess. So I would be worried about that. These vacant episodes may be seizure-like activity. So that's probably the next thing I would do. I don't think there's any need to add in IV acyclovir just because she's got cold sores. We do often see people developing or reactivating HSV cold sores. It doesn't mean they've suddenly got invasive disease. She'd be very unlucky to develop, invasive HSV encephalitis as well. I don't think a repeat lumbar puncture necessarily would add anything here. Again, we know that the sensitivity is correct for the strep pneumoniae, so switching over to another antibiotic wouldn't really be helpful. The transthoracic echo, the reason I put that there is a triad with strep pneumonia called the Austrian syndrome, which includes pneumonia, meningitis and endocarditis. So that is known. It's not common. I've seen 1 or 2 cases before, but it's just something worth considering if you've got somebody who's getting worse with strep pneumonia, invasive infection, and you're not quite sure why, and there is a murmur or some evidence of endocarditis. So she does have an MRI and an MRV. And it shows that there are filling defects consistent with dural sinus thrombosis and also signal change, which would be also consistent with ventriculitis, early ventriculitis, not cerebral abscess. And it picks up some inflammatory debris in the left middle ear, mastoiditis and meningeal enhancement in the area as well. So potentially the source of the infection to begin with. So this is a bit more of a complicated infection than just meningitis, and it does seem to be impinging on the brain parenchyma itself, and that's probably the cause. And in addition, she's got this thrombosis, which we know she's hypercoagulable, so that is a known complication of any CNS infection. So she gets anticoagulation for that. We ask for ENT input given the inner ear problems, and we decide to carry on the ceftriaxone for 6 weeks, actually given by the OPAT, outpatient antibiotic service. Normally strep pneumonia, you can treat it for a straightforward meningitis can be treated with 14 days of appropriate antibiotics, but in this case where you've got brain tissue involvement or even abscesses, you do need to treat for longer, minimum of 6 weeks and possibly longer than that, depending on follow-up scans. We always offer pneumococcal vaccine, and I think that's important to do because just because they've had the infection once, doesn't mean that they're not going to get infected by a different serotype. So we do always offer the vaccine. Now, really, this patient should have had her vaccine given her age by the GP practice, but it's something we would do on the ward. So just to summarise about pneumococcal meningitis, the mortality is up to 30%, so it's actually pretty high, and it increases with age and other comorbidities. Presentation can be with seizures, focal neurological symptoms and low GCS. These are actually more common than meningism symptoms, so don't be put off by the lack of meningism symptoms. Risk factors are older age, recurrent upper respiratory tract infections, as I said, head and neck surgery, skull fracture and CSF leak, and if they're immunocompromised. So slightly different sort of cohort of patients than Neisseria meningitidis, which is sort of your younger age group, people in close proximity to each other, halls of residence, students, that kind of thing. Now, there is a role for using steroids, and it's of benefit to prevent neurological problems later on. So when we add in steroids, it's actually, in case this is pneumococcal meningitis, steroids are not needed, or there's no benefit in other types of bacterial meningitis. So it is really for pneumococcal. So if bacterial meningitis is suspected, you should give the dexamethasone every 6 hours. You should give it with the first antibiotic dose, but you can give it up to 12 hours after that dose. And then if you've confirmed it, you give for 4 days. If you no longer suspect it, you can actually stop the steroids earlier. So that's just something for you to be aware of. I think I might have accidentally stopped sharing my, you can still share my screen, that's fine. Okay, are there any questions about pneumococcal disease before I move on to the next case? This case in particular? No? Okay. Case 2. So this is a 45-year-old man born in Malawi, but he's of Indian descent. Been living in the country for many, many years. Normally well, with no significant past medical history. So he initially attends, again, ED to AMU, with a week's history of general lethargy, a bit of myalgia, coryza, low-grade temperatures. This is pre-COVID, so it could easily have been COVID at the time. He and his family did note that he'd had a vasovagal episode that morning while he was sitting on the toilet. Seemed to last about 45 seconds. They weren't sure about seizure activity, but he was a bit twitchy at the time, but it settled very quickly. No travel, no unwell contacts. On examination, he was hypertensive, if anything, low grade temperature, but otherwise he looked well with no focal neurology and nothing really else to find. Those are his blood tests. UNE's normal, slightly raised bilirubin, maybe slightly raised white cell count, probably bordering on normal, slight neutrophilia, low lymphocytes, CRP of 33, not that exciting. HIV was done, it was negative. So at the time the diagnosis was this is a viral illness with maybe a sort of vasovagal episode, maybe all of that was secondary to his hypertension. And he was sent home with an outpatient MRI and a first fit clinic. So that's what they decided to do in AMU that day. Obviously wouldn't give you the microscopy report to look at, but this was the thing that they had seen in his blood culture when they did a gram stain. So they'd incubated his blood culture, gram stained it on the first day, it sort of pinged as positive, and this is what they saw. So I'll give you a clue that these are sort of pink this time rather than purple. And so you want to look out for these things, which are, again, I'll give you a clue, organisms, the shape of them, what kind of configuration do they have. So what's the most likely organism here? Is it Haemophilus, Klebsiella pneumoniae, Listeria, Neisseria meningitidis, or Streptococcus viridans? Again, any budding microbiologists or ID interested people here to point out? So I'll break it out. Anyone think this is either gram positive, gram negative?
Negative.
So don't be put off by the fact that that's actually two organisms together. So they're in pairs. So these are actually cocci. They're diplococci because they're in pairs. So gram-negative diplococci, does that ring any bells?
Neisseria.
Neisseria, absolutely. So that is very typical of Neisseria meningitidis. There's not many gram-negative cocci to be aware of, but the ones that you do need to be aware of are the Neisseria species. So both Neisseria meningitidis and gonorrhea look like that. But in this context, you would be worried really about Neisseria meningitidis. Haemophilus, yes, it's a common infection of the causing pneumonia and also meningitis, but less so now because of vaccination. That's a gram-negative bacillus, Klebsiella pneumoniae. Again, gram-negative bacillus, commonly causing, UTIs, intra-abdominal infections. Listeria is actually a gram-positive bacillus. So again, not many gram-positive bacilli to be aware of. Most of the ones you'll come across are gram-negatives. Strep viridans associated with endocarditis. It's a gram-positive coccus again. So this is a Neisseria. So who do you think should be it keeps going. Sorry about that, I'm sort of skipping a lot. So at this point he's readmitted. Obviously you're worried about him. He looks unwell. He looks well, sorry, still. He's unsure why he's actually been called back. He's still got some myalgia and coryza, a bit of headache, no dysuria, no abdominal pain, no joint swelling, no cough, no diarrhea, vomiting, not really any photophobia or any focal neurology at all. He's afebrile, obs are stable still, cardiovascular is fine, no rash, no joint swelling, GCS15, no papilledema when you look. So what's the next best management step for him, do you think? Would you repeat his blood cultures? Maybe it was incorrect. Would you do an echo, LP, a CT scan first and then an LP, or scan the rest of him, instead, because there's not really anything neurological apparently going on? Think of this as this is a real case. I had to think about what to do. What would you guys do? Would you be worried about this? I think personally, if this was, if that had been called up, unless I'd got completely the wrong person, I would be worried about this being a real, a real infection. But I think repeating the blood cultures would be reasonable. The question about doing an LP or not would be interesting. I think I would. I mean, he's got the headache, he's got some CNS symptoms. So I think we would really need to exclude CNS infection. With Neisseria, you can just get the bacteremia without meningitis. So you can get invasive Neisseria infection without the CNS infection, but I think he's got enough symptoms there with that funny vasovagal episode and seizure-ish maybe activity to do the LP. The question is, would you do the CT head or not? And I think that is something that we need to think about, and I'll discuss. So he ends up having a CT head anyway, which was, standard, I guess, from A&E and AMU, which is normal. And the LP is done, it actually looks normal as well. But microbiology do confirm that that blood culture result was of Neisseria meningitidis. So he's got a Neisseria bacteremia. So he's given ceftriaxone, which is perfectly, standard for Neisseria. 2 grams once a day this time for 7 days. Now, normally you guys will be used to 2 grams BD for ceftriaxone. The reason for that is for the Neisseria dosing, but it's actually only what's indicated for CNS infection. If there's no evidence of CNS infection, you can give once a day and actually for a slightly shorter course as well. So he is put in a side room and barrier nurse for the first 48 hours, which is when, as I said before, you're most at risk of passing the infection on with Neisseria because it's carried in the pharynx. And PHE is informed. Close contacts in this situation do need to be given chemoprophylaxis. So you can either give ciprofloxacin as a single dose, which is usually the easiest thing to give because there's not many, fewer side effects, not many drug-drug interactions. But in this case, because it was resistant, they were given rifampicin as well for 2 days. But we just got to be careful with rifampicin and causing lots of drug side effects before giving it. And actually, at the end of that course, he did well, and he was allowed home to complete his antibiotics. So just be mindful, actually. So Neisseria, most of the time, we see the horrible pictures of non-blanching rash and septicemia and really severe CNS infection, meningitis and encephalitis. And clearly, we should always be aware of that. But I have personally seen a few cases exactly like this. I've seen somebody with spondylodiscitis, a spinal infection instead. And a couple of cases of actually more GI symptoms as well. So it can behave slightly unusually, Neisseria. Any questions about Neisseria?
They usually look worse by the time they come to us.
They do. I know they do. You'll see everyone looking, the worst of everything, I'm sure. But I guess there are times when we see the earlier bits and hopefully it didn't get to that stage. But so this question about LP or CT first. I mean, in reality, I think everyone's usually very concerned and a little bit conscious about scanning. I think everyone pretty much gets a scan, with a whiff of any neurological symptom. But actually, the guidelines. So this is the British Infection Association and many others. Suggest really that an LP should be performed within an hour of arriving to hospital if you're concerned about meningitis. An urgent CT head is required before LP only if there are clinical signs suggestive of a shift of brain compartment, so that's GCS, for any focal neurology, seizures, and really a papilledema on fundoscopy. But if you can't see the fundi, then that shouldn't really, it doesn't mean you shouldn't proceed to LP especially if it's a short illness. So that's actually fairly clear. And it's just worth remembering that even if you do a CT, you may not fully mitigate the risk of herniation. So it can be a sort of, falsely giving you a false sense. How many times have I actually done it in reality, or have I been in a scenario where the scan wasn't done? Very few. I think I've personally had the opportunity to make that decision or make that call a handful of times where the scan's not been done, and when I've done the LP, it's pretty much been fine. There haven't been any concerns, without the CT scan. But I know, litigious situations and not being sure, not having access to a fundoscopy and all those things, sometimes I find CT scans are easier to get here than X-rays. I think the reality is that many CT scans will be done before the LPs when they're not indicated. An LP, also remember, shouldn't be done if there is suspected meningococcal septicemia. So if you see that typical rash, don't delay. Just give antibiotics. Don't delay. Whether it's for LP or for CT. So that's just something about the scanning versus LP. So case 3. It's a 40-year-old lady who's 10 weeks pregnant. She's got no significant past medical history except migraines. She presented to A&E with a 2-week history of gradually worsening headaches with nausea. And she said this was very similar to what happened in a previous pregnancy, but the only difference is in the last few days, she'd also developed fevers and severe photophobia. So that was quite different to last time and her usual migraines. On examination, she had low-grade temperature, OBS were fine, GCS was fine. But she's sort of a typical patient that some of you might have seen, sitting in a darkened room, bandages over their eyes, don't really want to look at the light or have you turn the lights on. Cardiovascular abdominal exam, all normal. She definitely had neck stiffness, but there was no focal neurology. So obvious signs of meningism, really. She has an ultrasound of her pelvis. There's a viable pregnancy. That's all fine. These are the blood tests. So slightly raised white cell count and neutrophils. CRP less than 5. Other blood tests look okay. She has a CT brain, including a CT venogram, which I think is a reasonable thought in pregnancy, a venous sinus thrombosis. And again, she gets started on IV ceftriaxone and IV acyclovir in A&E, probably sort of a standard thing for meningitis. The lumbar puncture is done. It's this time clear and colourless. White cells are raised at 385, 99% lymphocytes, no organism seen. Glucose 2.5, again no blood glucose though, and the protein's very slightly raised at 0.8 with the limit being put 0.5. We ask a few things: no travel, no unwell contacts. She remembers accidentally eating some soft cheese a week ago, and that was specifically asked. What's the next best management step here? Again, another antimicrobial treatment question. So would you continue the ceftriaxone and the acyclovir? Would you do that and add in amoxicillin? Stop the ceftriaxone, but carry on, stop both things. Stop ceftriaxone, but continue the acyclovir, or stop the ceftriaxone, continue the acyclovir, but also now add in amoxicillin. So any thoughts about that? So I mean, what am I getting at here with all these choices? What again, like the other question, is this more likely to be bacterial? Is it viral? If it's viral, does it need treatment? Those are really the 3 points I'm raising here. So any thoughts about that? Or any particular risk factors?
I think it's likely viral infection.
Mm-hmm. And why do you think that?
I mean, she's not particularly sick. I know that doesn't mean anything, but that's one thing. And secondary, looking at the LP itself, it's got lymphocytes.
Mm-hmm. Yeah, it's predominantly lymphocytic, isn't it? So that is a very typical viral CSF picture. 99% lymphocytes, hardly any neutrophils. The white cell count's pretty high. I mean, we often see slightly lower white cell counts with viral meningitis. And again, difficult to compare with the glucose, but that protein being sort of just mildly raised very much fits with the viral picture. And just remember as well, she hasn't got any neurological symptoms really, apart from the meningitis. There's no signs particularly of encephalitis, and that's really where acyclovir is indicated if there's any evidence of encephalitis, not just meningitis. The soft cheese, why have I added that there?
Is this the risk of listeria?
Yes, immunocompromised, and actually being pregnant in itself. So that's why that it sometimes comes into people's minds about thinking about listeria infection in pregnancy and listeria meningitis. So that's the whole point about thinking about whether we need amoxicillin here. So actually, so based on what we've said, what would any sort of you had to make a decision, what would you do? Who would just carry on everything until they know a bit more? And who would think, right, actually, let's be pragmatic and she's pregnant, we don't really chuck drugs out that we don't need to. Would anyone stop everything? Anyone be brave enough to do that?
I think I would rather continue everything just in case with the immune compromised state, and she might not have mounted a great response. So I think excluding anything at this point might be a bit dangerous potentially.
Okay, and when would you think about either then carrying on to finish a course or stopping eventually? What would make you change your mind or make you make a decision one way or the other? Clinical response, results?
Probably results would be a bit of a chicken, I think.
Yeah, that's perfectly reasonable. You know, with CNS infection, we don't, you know, it's hard to sort of mess around with it, isn't it? So, you know, I wouldn't blame you for wanting to do that. So I'll mention this thing about listeriosis actually. So it's a spectrum of infection from self-limiting flu-like illness, which causes a bit of gastroenteritis, to being invasive, and that's where you can get your bacteremia, quite severe septicemia and meningoencephalitis. So again, not that common, but we have seen, you know, we do see a few cases from time to time, and when you see one, you know, it's hard to forget. So it tends, the CNS side of infection tends to happen in immunocompromised and older adults and in neonates. They often have a subacute fever, maybe quite as acute as Listeriosis. Cranial nerve palsies, ataxia, tremors, and hemiplegia, what's called a rhomboencephalitis. And again, the CSF, you actually get a mixed picture, and that's sort of, you know, why you might have considered listeria in that CSF that we just saw. You do get a rise in protein, but you tend to get a low glucose, a bit like, you know, like any other bacterial infection. So in pregnancy, so bacteremia is not, you know, is relatively common, which is diagnosed from the blood culture, but actually CNS infection, meningitis, is quite uncommon. We don't see many cases, but if a pregnant lady does get infected, there is a significant risk to the fetus, and particularly stillbirth or miscarriage, and especially in the first trimester. So that's why it is dangerous, and that's why we do ask pregnant, you know, women to avoid soft cheeses, pâtés, that kind of thing, where you tend to find listeria infection. So it's just worth remembering that in this case, you know, she didn't really have any of the clinical features of the encephalitis, and the CSF picture wasn't quite fitting either. But and it's very unlikely for this to be listeria in this case. So what do we do? I think I saw her in A&E and AMU, and I said, look, I really don't think this is bacterial from the CSF. She's not got encephalitis, so the acyclovir is not indicated. IV acyclovir is not indicated. So I stopped everything, transferred her to IDU, and just gave her analgesia and supportive therapy, which is what you would tend to do for most viral meningitis. The fevers did settle, and she remained well neurologically, but her headache didn't settle at all, and she actually remained quite uncomfortable, and again would sit there with her eyes covered. And then the CSF virology came back, showing that this was herpes simplex virus type 2, and that was quite interesting. So if I talk about, we'll go on to talk about what we should do next, but what would you do next, you know, and what the relevance of the HSV2 is? Would you continue supportive management? Would you think about encephalitis, do an MRI brain, an EEG? Who'd restart the IV acyclovir? Would you give oral valacyclovir? And I guess this sort of comes down to what you know about HSV infection.
I'm going to say no, people don't know a huge amount.
Okay. So, I mean, when people talk about HSV, you know, it is particularly HSV type 1 is associated with encephalitis. And that's the one that tends to cause cold sores. There's two types of HSV, and HSV type 2 is mostly associated with genital infection, so sexually transmitted infection and genital ulceration. And interestingly, HSV2, especially the first episodes of genital ulcers, can be accompanied by a viral meningitis. So the way I think about it is HSV2 linked with meningitis, and HSV1 is linked with encephalitis. Obviously, things can overlap, and one can do the other, but in the majority, that's how it tends to be. So she didn't develop an encephalitis, so really IV acyclovir wasn't warranted. But because she was so symptomatic with it, I did opt to give her a 10-day course of oral valacyclovir, which actually has really good bioavailability and is just as good in many cases as IV acyclovir. And that was really to reduce the severity and duration of her symptoms. We asked about ulcers, there weren't any, and she was discharged once a headache and meningitis gradually improved. So I didn't follow the things that you might do for HSV encephalitis. That's where the repeating the LP, MRI, EEG, very much part of the management potentially for HSV1 encephalitis. But because there was no symptoms of brain tissue inflammation, encephalitis, it was really just a meningitis here. We gave treatment, and that you could argue that maybe the carrying on the treatment at the beginning would have helped her symptoms or not. And so just an overview of viral CNS infection. So with meningitis, actually, enterovirus is the most common cause, and the enterovirus family includes Coxsackie virus, which is the same one that can cause hand, foot and mouth disease. So many of you have young kids will have had children who come back with really sore mouths, and if you get it, it's actually pretty nasty. So that's what an enterovirus is. So these are self-limiting infections which just get better on their own, and that's why there's no specific antiviral really for enterovirus or for many enteroviruses. So in general, viral meningitis without any encephalitis, because this is the most common pathogen, it does not need acyclovir. HSV2 may occur, like I said, with the first appearance of genital ulcers, and you can get this sort of recurring syndrome, which is called Mollaret syndrome. And in those cases, we sometimes give them prophylactic acyclovir, which is often what we do for people who get recurring genital ulcers as well. And there's a few others to be aware of. So varicella zoster. So if you get somebody with ophthalmic shingles, that's often associated with CNS infection. So you have to be really careful about ophthalmic shingles and concurrent CNS infection, particularly in the elderly or immunosuppressed. And sometimes primary HIV infection can do this as well. So just a sort of word of warning about meningitis not needing acyclovir. HSV1 is associated with encephalitis. It's usually in the immunocompromised. And other infections that might be linked with this are other human herpes viruses like HHV6, some of the glandular fever viruses, as I said, varicella zoster, JC virus, which is the one in HIV, advanced HIV, which causes PML, and a few other weird and wonderful travel-related infections. So again, these would often warrant treatment, particularly HSV1 and with symptoms of encephalitis. So as I said, IV acyclovir only indicated for HSV, encephalitis, or VZV, where it actually still works with neurological involvement. And you do need to give a minimum of 14 days of treatment, but sometimes up to 3 weeks. There's no studies for using oral valacyclovir instead, but it probably is effective. So I have had some scenarios where we've never identified the organism, the viral PCRs weren't positive. We have to sort of make a decision, whether we treatment, which mostly needs to be in hospital, or whether we step down to oral. There's no evidence really for it, but because we know the bioavailability is good, we'd be generally happy in that scenario to switch over. And in this case, as I said, the HSV2 meningitis, we know it works, the acyclovir, the oral version, and that was mostly to reduce the symptoms. And I spoke to the virologist about this case, and he thought that would be, Julian Tang thought it would be a good idea, and also potentially some, reducing a very slight risk to the fetus as well. I'm conscious of time because of all the faffs in IT. I have got one other case. Have I got time to do that or not?
Yeah, I think so.
Yeah, okay. So a 50-year-old man lived in the UK for about 15 years. He presented to A&E because a member of staff found, to be confused and agitated at work that day. Not noticed to be unwell before, though. So this is sort of quite unusual behaviour that day. There was a limited additional history, as the patient was very confused, but we managed to get that she lives alone, no family members. There'd been a recent travel to Spain for a conference a couple of weeks ago, and a trip to Thailand 4 months ago where she was visiting family. But apart from that, there really is no significant past medical history we can get out of her. So on examination, she looks unwell. So febrile, blood pressure and is okay, heart rate's up, saturating quite well, drowsy but rousable to voice, GCS is put at about 12, cardiovascular exam is normal, no neck stiffness, cranial nerves look intact, no other focal neurology, and again gets the obligatory sepsis 6 management, meropenem in A&E. CT head, a non-contrast CT head is normal. Those are a blood test, so slightly low sodium, actually normal looking white cell count and full blood count really, apart from slightly low lymphocytes. CRP is only less than 5. Someone thinks about malaria, given that trip to Thailand, that's negative. HIV is negative as well, and that would be a good thought in this case. An LP is done, so white cells are raised. Remember, for those not familiar with LP results, the lowest sort of acceptable number is 4. So white cells of 95 is high, predominantly lymphocytes, but there are some white neutrophils in there as well. No organisms are seen in gram stain. The glucose is very low, so less than a third really, pretty much, yeah. And the protein is high as well. Remember that borderline, the sort of upper limit of normal is about 0.5. Managed to get through to system 1, GP records, 1 minor visit, no significant past medical history, no regular meds, and there's a penicillin allergy, which is anaphylaxis. So you've just had a stat dose of meropenem. At this point, what would you do next in terms of antibiotics? Change to ceftriaxone, give the IV acyclovir with it, continue meropenem endacyclovir, or do something completely different. So again, what I'm getting at is here, what do we think this fits with? Is it more bacterial, viral? And when we think about this, we always have to think the overall history as well. So acute, subacute, other risk factors for immunosuppression or things like travel and pathogens that maybe aren't so common. Any thoughts?
So the history and the high protein, low glucose, just bacterial. But the lymphocyte being raised points towards more viral. So I'd probably, on the balance of it, go for the meropenem and acyclovir option.
Sure, and I think you're right that the CSF is a bit mixed, isn't it? So on one hand, you've got biochemistry of a bacterial infection, but you've got the sort of the white cell picture of a viral infection, and you've got sort of a lack of inflammation in the blood as well. So that's all a little bit strange too. But also she's clearly quite unwell. So I would have veered in the same on the side that you and gone for covering both. She's a bit young, I think. Remember, yeah, well, actually borderline for thinking about a listeria, sort of 55, 60 plus. But if you're going to give meropenem, we know that will cover listeria as well. So I probably would have given meropenem and a IV acyclovir and then waited for some tests. So that's exactly what happens. So
if she's anaphylaxis to penicillin,
dose, yeah. Oh yeah, so that's the other thing. Yeah, forgot about that. Yeah, forgot about the anaphylaxis. So that's why actually ceftriaxone wouldn't be appropriate at all, because as remember with penicillin allergy, there's 10% cross reactivity with penicillin and cephalosporins, and about 1% with meropenem. Now, generally speaking, depending on what you read, it says all beta-lactams should be avoided in anaphylaxis, but actually in reality, and I think with most UHL guidelines as well, if you discuss with a microbiologist, they'd be happy for you to use meropenem in that situation if you really needed to. But obviously you're in a place of safety, you can monitor them. I think that would be reasonable to give meropenem. But you're right, there would be some concern, and if it was if there was anything that worsened, then it would be, you'd stop that. It'd be very challenging though after that what you could give. So you could give quinolone, so something like levofloxacin also covers most of the CNS bacteria. You could go very old school and give chloramphenicol. That is sort of a dirtier drug, but we have had to give that in some scenarios as well, where we were really worried about the anaphylaxis history. But yeah, so in this case, with caution, I'd use meropenem, and she'd had a dose and she hadn't reacted to it in A&E, remember, so that was a bit more reassuring. Were you reassured by that, or would someone think, no, I'm not going to do this? That's what happens, and she's fine. So after about sort of 24 hours or so, she's still febrile, and there's not really much improvement. Intermittently drowsy, and confused, and every time she's got a fever, then those of the drowsiness gets worse. The CSF comes back, it's not that helpful. Viral PCR is all negative, and remember with HSV, it's very sensitive and specific. So as long as it's not done too early, as in within hours, a negative viral HSV viral PCR is very, very sensitive to and you can pretty much exclude HSV. Meningococcal, pneumococcal culture, well, it is negative to date. PCR for both of those infections is also negative. There's not really enough CSF left for anything else to add in any other tests. So we managed to get a bit more history from friends. She'd been coughing since a trip to Spain, which was a couple of weeks ago, where she stayed in a hotel, taking some over-the-counter meds for that. No other unusual activities or sexual contact that they were aware of. And then she's been complaining of a headache pretty much for the last 2 weeks since returning. And now had she become confused. So this is sort of feeling like more of a subacute picture than a very acute one. This is a chest X-ray. On the face of it, you might think it's normal, but I'd be a little bit concerned about some of these interstitially looking scarring, maybe in the upper zones, and something in the right mid zone. It's just not quite normal. What's the next best management step, do you think? Would you add empirical TB treatment? Add levofloxacin because you're thinking about atypical pneumonia, that is. Do a CT chest, repeat a lumbar puncture for further CSF, send the sputum for culture, urine for Legionella antigen. We could do pneumococcal antigen as well. Any thoughts?
Dr. Briggs says, have we done HIV and Legionella testing?
So HIV was done before, that was negative. And the Legionella, so that's one of the options. So somebody would think about doing that. I think that's reasonable because of the odd sort of slightly subacute respiratory symptoms, dry cough. And you could do those, and obviously they'll be back, within 24 hours. You've got somebody who's potentially unwell though in front of you, not getting better. So either persevere with the current treatment, think about something else. So those are the sort of the thoughts about that went through my head at the time. This is a patient I saw in AMU. So what did I do? I did ask for repeated lumbar puncture because I was a bit concerned about TB actually here, partly because of the subacute history, the CSF picture, which can also be quite mixed looking in TB. And we need a lot more sample as well for looking for TB. So both a smear test and culture, you need at least sort of 20 drops for TB culture, something to be aware of if you ever have to do another lumbar puncture, particularly looking for TB, just get loads of CSF off them. So CSF is sent off for AFB and TB culture and other tests as well. AFB is negative, which often is in TB meningitis. And I opted to start off empirical TB treatment. So the standard 3, rifampicin, isoniazid, pyrazinamide, which you can remember, rifampicin and isoniazid you can give IV, and with her I was quite concerned about her not being able to, sort of neurologically being able to swallow meds, so that you can give IV. Levofloxacin has anti-TB properties, so that's a good one to give instead of ethambutol. And pyrazinamide is the only thing you can't give IV, so but at least she's getting 3 drugs down her, and if possible she can take the pyrazinamide if able to. So again, just be mindful of that. So if with TB treatment in ITU, where people are obviously very sick, we often will go for the IV versions of those drugs. So levofloxacin on its own, although that's fine for something like Legionella, just remember it does have, it does treat TB. So if you gave it on its own, you are potentially giving TB monotherapy, which wouldn't be appropriate. And so dexamethasone is indicated in TB meningitis. So there aren't many situations where you need to give steroids with the TB drugs in TB treatment, apart from in CNS TB and also pericardial TB, because often when you start TB treatment, as the mycobacteria are killed, it sets off quite a significant inflammatory response, a paradoxical inflammatory response, where things get a bit worse initially, and obviously in the brain that could be very, very dangerous because there's limited space for movement really in terms of swelling. So we add in steroids as well. Acyclovir, I was happy to stop. It wasn't really a viral picture. The viral PCR panel was negative, but again, meropenem I continued to cover the bacteria while we were trying to find out what was going on. And I requested a CT scan as well, collect some sputum, again, for standard culture and TB testing also. So this was the upper on the CT scan, and there is, I hope you can make out some ground glass shadowing there. I was for lung infection. So we transferred to IDU in a negative pressure side room, and actually on that regime she had significant improvement in both fevers and cognition over the next couple of days. And when she was able to give more of a history, she was able to tell us that she was actually diagnosed with gastrointestinal TB in Thailand when she was 25 years old. She didn't really have much information about that. She doesn't think that they took any cultures or managed to properly prove that it was TB, and she believed she received 6 months of treatment and completed the course. And that's quite significant. Not that treatment was given the first time round, or if the person did take their treatment fully. So we also did a bronchoscopy, which was negative at that time, and she was discharged a couple of weeks later to carry on her TB treatment at home with the TB nursing support when she was well enough. And CF cultured TB after 21 days, which was thankfully fully sensitive, so we were able to carry on with the normal drugs, the standard sort of ripe drugs, weaned off the steroids, and the total duration that she got was 12 months. So this again is not an unusual scenario. I'm sure you've had some cases of TB meningitis that have gone badly wrong in ITU. We probably see a case of CNS TB once a month. It appears, that's sort of anecdotally me sort of saying that. So I would just be mindful of anyone who works, either ITU or in the future in A&E or AMU. Just think about TB, extrapulmonary TB, particularly TB meningitis, because there's a lot of that unusual sort of CSF picture. I'll finish, if I've got time, with just talking about the UHL guidelines for meningitis and meningococcal septicemia management. Pretty much what we've talked about: recognize and treat within an hour, an LP within an hour if safe to do so. LP before antibiotics obviously makes sense, unless they're septic. Check the opening pressure, bloods and CSF to include PCR, and consider additional risk factors, for the reasons that we've said: immunocompromised, travel abroad, TB risk. In terms of empirical treatment, if there's anaphylaxis to penicillins, cephalosporins, meropenem is fine because it covers, as is pretty much everything, including listeria. Otherwise, give Keftrax, so 2 grams BD. And if they're over 60, pregnant, immunocompromised, cover for listeria by adding in high dose amoxicillin, so it's every 4 hours. And then obviously adjust to the micro results, and steroids we talked about. Have I got time very briefly in a minute to cover this audit? Or I know that you had in the presenter.
Yeah.
Okay, so we thought we'd look at an audit of how well we do things at UHL. It's a few years old, so it's worth repeating actually. And we measured meningitis diagnosis, both bacterial and viral, presenting over about a year against the trust and national guidelines that we have. Over that time, there were 35 patients diagnosed with meningitis, which actually is probably fewer than I thought, with a mean age of 41. The final diagnosis was coded 10 being bacterial, 22 being viral, and 3 other. All patients with suspected bacterial meningitis fortunately received appropriate antibiotics. Median time, I think this is to their first dose, 64 minutes, so that's actually not too bad. 13 patients received acyclovir when it wasn't indicated. 6 required listeria cover, but only 3 of them got it. And only 4 of that whole sort of cohort 35 received steroids. 2 of those are bacterial, 2 of those were viral, but 2 of them got it when they didn't need to. And obviously 2 of those bacterial never got it at all. And the 2 that didn't receive steroids had confirmed pneumococcal disease and actually ended up developing cortical blindness and bilateral hearing loss. So, you know, obviously a missed opportunity there. The mean time to lumbar puncture was 29 hours, which, you know, clearly beyond the guidance, and it was done sooner if admitted in the morning, you know, in the day, in normal working hours, which, you know, I can see why that would happen. You know, after hours, things get very busy on people put things off, say, oh, we'll do it in the morning. They've got away, so you know what's the point? It's a clear indication. Only 6 had an opening pressure recorded, and that can be very helpful. Serum glucose only sent in 3, and 55% of LPs were conducted by registrars. Opportunity to learn lumbar puncture in MT or ACCS, and that would clearly make a difference to when a patient gets them. Just running a risk to do them, then obviously there's going to be a delay. So the learning points from this audit were LP should be conducted earlier, CT scan should be conducted less frequently, with more fundoscopy available, so fundoscopes around to facilitate this, to look for papilledema. More steroid use, actually, so we weren't probably using it enough where it's appropriate. Less acyclovir use. Remember, acyclovir isn't risk-free IV, it can cause renal failure, nephritis. And thinking about who should be conducting them, the LPs, really. So who do you guys think? Should it be the A&E doctors in A&E, which they, at the moment, point blank refuse? Medical doctors going to A&E to do it, which is not unreasonable. Medical doctors in AMU, someone else. Maybe ITU should do it. Any statistics? I'm going to end there, but just any sort of thoughts on anything else? I know I've gone, you know, quite a long time.
I'm always surprised by how many patients come to ITU with neurological symptoms, presumed meningitis, who haven't had an LP by the time they get to us.
Yeah. Oh, even to ITU by the time they get to ITU. Wow.
Yeah, and it's one of our jobs on admission for us to do it because nobody's done one before. So after we've intubated them and put them on a ventilator and put all their lines in and all the other stuff that we have to do.
And from your personal experience, why does it end up? Why do you think it hasn't been done? Is there ever any clear? Is there a good reason why it's not been done? For instance, so they're unstable.
They're not usually unstable. I think people are worried about GCS and thrashing about and stuff, and sometimes we end up tubing them to make them safe, which is potentially a good reason if they won't stay still. You don't want to stick a needle in their back. But yeah, sometimes it just people seem to get distracted by the fact that the patients are sick and don't do the things that they do need to do, like an LP.
Yeah, and I think it's quite a contentious one. I mean, I personally think that there's no reason why A&E can't do lumbar punctures. You know, if you can put in a chest drain, then it's not, you know, and it's not. It's in. I think it's in the ACCS sort of ED training. I think it is. I've read that it is from a while ago. So they can't really use a training card. It's not one of our core procedures.
I did it when I was in ACCS training.
But an accepted thing now.
Yeah. Paris?
Yeah, I was just going to say, staffing is often an issue because you at least need, often at least need 2 people, so a nurse to sort of hold the patient's hand if they're on the left lateral and sort of talk them through it, and then a doctor to go through the procedure. So particularly in the wards and in A&E, when you've got one nurse to X amount of patients, they have to then stand there and sit with the patient to do the procedure a lot of the time. So I think that's one of the issues, I feel, and having spoken to a few of the doctors on the wards, I think that resonates throughout. And then out of hours, say some of the ACCS trainees who have only done one lumbar puncture or have only seen one will have to be supervised by the registrar, who's actually trying to firefight in several places. So it's not so much a not wanting to do it or partly skill mix, but also partly just not having enough trainees or nursing staff to be able to facilitate it.
I think that's probably right.
No, I do agree with that. It is often a more than one person, sometimes even more than a 2-person task if you've got someone who's a bit agitated. And I think it can sometimes fill people with dread. Not actually always as straightforward as they as they could be. So I can see why if you're in the middle of the night, you might just think, oh, I really can't be asked with this, or leave it to the day staff. We've got more time, more staff. They've got their antibiotics going and all that kind of stuff. But it does make a difference to results.
Yeah. Kaya?
I think that there's also a couple of other, it's a multifactorial issue. So some of the results should be in the lab quite quick. So the worry about the delivery of the samples to the lab, that's definitely something that I came across with. And another thing is they created a consent form with a sticker now. So maybe issue with actually obtaining consent from the patient, apart from the things that were mentioned from Paras, that person who actually can do it, how to do it, talk to the patient, explain why they need to get the procedure done. And unfortunately, the same as you said, Zoe, that sometimes when they arrive to us, we just need to intubate, put the lines in, and then do LP, because that's what left, essentially.
Yeah, thankfully with the nucleic acid test, nucleic acid amplification test, PCR, they haven't been positive for a number of days, but it also depends on the burden of disease and how long. If you've left it a couple of days, it's going to be much less helpful. But PCR tests are actually quite useful, and you could hopefully get away with it with those. But the hardest situation is when you've got someone who's been started on antimicrobials, they're on their Keftrax and acyclovir, and they've often been on it for a day or two. There's been a failed attempt, and then everyone's like, well, we're not going to do it again for whatever reason. It was too difficult, or the patient doesn't want to, and so we're often left to make a decision. From our infection point of view, we're left to make a decision about what are we treating this as encephalitis or meningitis or not? No one's committed themselves. So the start of the treatment, no sort of a full diagnosis has been made, and then it needs to either we'll do it thing as well. We're used to doing a lot of them, as you will be in ID. So our registrars can often do them fairly easily, or we have to then commit them to 7 to 14 days of treatment. And they'll be potentially in hospital for all that time. So it does make a big difference actually to have that evidence at the start.
Yeah. That's why we call you for help. Thanks very much, Aman. We better move on to journal.
No, that was helpful.
Yeah, no, really good.
Yeah.
Thank you.
I might leave you there. Thank you.
Yeah, carry on. Right. Now we're having Journal Club, and Fran has stepped in at the last minute, thankfully. Thanks very much, Fran. So pass over to you.
You're welcome. Well, you can tell me later if you're grateful or not. So I've got this paper to discuss today. The title is Conventional Oxygen Therapy versus CPAP as the Ceiling of Care in Ward-Based Patients with COVID-19, a multi-centre cohort evaluation, and published last year. So I guess the first question is, does this apply to me and my patients? I guess it kind of does, because we say, oh, we're not going to admit that patient for invasive ventilation. You should just have CPAP on the ward, and that be your ceiling of care. So is the advice that we're giving actually sort of, what does it stand up to the test really? And I just wondered, just having heard the title, if anyone, without any leading questions, what do you think that this might show? Jump in.
Are they going to die?
They're going to die. Yeah. And they are. So let's carry on. So CPAP became the standard of treatment for viral pneumonitis sort of in COVID, really. It hadn't been used for this much before, but it gained traction during this time. but there's still not much evidence when they produce this paper. And recruitment for Recovery RS, which is looking at CPAP and high flow nasal oxygen in the COVID cohort of patients, is still recruiting, and actually it's only looking at patients who are being admitted to ITU and then would be eligible for invasive ventilation, so it doesn't actually cover this cohort. There's a small Italian study looking at CPAP in COVID-19, and it looked at 60-day mortality, and that was 73% in their cohorts of patients. So the UK guidelines kind of followed expert consensus rather than any evidence from studies. And this study is a retrospective multi-centre service evaluation, and it compared the outcomes of patients who either received ward level oxygen or ward-based CPAP as their ceiling of care, and it was across 7 hospitals in the northwest of England, 2 of which did not offer ward CPAP, so the only option there would have been either admit to ITU HDU for CPAP or stay on the ward and have only oxygen. And the recruitment periods were during what you would consider to be wave 1 and wave 2 of COVID, so back in March to May 2020, and then again in September to November, December time 2020. And their primary outcome that they were looking at was 30-day mortality. The secondary outcomes were time to death or time from inclusion to hospital discharge, so time from initiation of that ward-based oxygen therapy, which was an FiO2 of greater than 0.4, or being on CPAP for greater than 12 hours. They must have had a COVID positive test of some kind or a diagnosis of COVID based on radiological findings, and it being the most likely diagnosis, and a clinical frailty score of less than or equal to 6. They collected characteristics of age, ethnicity, obesity, so BMI of greater than 30, urea, CRP, and then some bedside physiological variables, so SATs, respiratory rates. They also collected maximum CPAP pressure, maximum inspiratory oxygen fraction, and then they looked at discontinuation of CPAP and whether that was patient initiated or the medical team initiated it, and whether that was because of recovery or futility. So they performed a myriad of statistical investigations on their data, and they sort of looked at unadjusted associations between 30-day mortality, and then tried to find some other explanatory, sort of tease out some explanatory variables, including the treatment. And they did a univariate regression modelling rather than multivariate, so they didn't include all those different variables to try and find out which one was more responsible. And then they also produced a Kaplan-Meier curve to illustrate overall survival. They did examine in more detail the relationships between some of the independent variables using some other statistical examinations, which I did ask Dr. Scott about, and I came away not feeling that much the wiser. Sorry, Simon. They tried to minimise selection bias by 2 of the hospitals could only provide ward-based oxygen, and the other 5 also could provide CPAP. So the patients who they kind of matched up who were receiving only oxygen were from hospitals where it was only an option to receive oxygen, and the patients who had CPAP were at hospitals where CPAP obviously was an option. And they also then looked more carefully at their comorbidity scores and their frailty scores, and they tried to also make sure that there was no clustering at different hospital sites. So across the hospitals, they managed to collect just under 500 patients' data. They exclude initially anyone who was sort of looked at. If they had CPAP with an FiO2 of less than 0.35, they're excluded. If they're extremely frail with a severity score of greater than 6. And then they collected all this other baseline data, which I'm not going to go into. It's available in a table, but essentially the groups are not that different. They're mostly men, they're mostly white, and their mean age is 77, and there's not much difference between the 2 groups. It's pretty much what you'd expect from that COVID cohort. So results, they found, sorry for shuffling papers, I should have stapled it together. That between the two groups, there was an overall mortality, 30-day mortality of 76.2%. So quite similar to that Italian study. And when they looked at the oxygen group, the mortality was 75.6% and 77.7% in the CPAP group. So there was no significant difference seen between the treatment groups. And there wasn't any difference between the secondary outcomes of survival time or length of stay in survivors. And then they, even in the adjusted model, so they looked at to see whether treatment, if you were older, you had an increased mortality regardless of whether you got CPAP or wall-based oxygen. If your urea increased, you had increased mortality regardless, and if you had lower saturations, you had increased mortality. And they discuss a bit about how CPAP, obesity, survival and COVID are interrelated, because obese people tend to get more severe COVID, but they also benefit more from CPAP potentially because of their body habitus. I mean, they might be amenable to some recruitment with CPAP, and the benefit of being in that patient group was less once it was adjusted. So obesity had a lower impact once they had adjusted for it within their group. And they looked at between the different waves where maybe care changed, and we had some more information about looking after patients in wave 2, and that made no difference. And they actually haven't published in this paper the time to discharge or death. Then they discussed a little bit about CPAP discontinuation. So I think in about half of all the patients on CPAP were discontinued on CPAP, and around half of those were because it was medically felt to be the right thing to do, either because of futility or because of recovery, and half of it was patient initiated. And then they looked to see whether, if you were a patient who took the CPAP mask off and refused to put it back on again, whether that meant you were almost certainly going to die. And actually they compared, it wasn't a statistically significant difference if you declined CPAP. It didn't actually make that much difference as to whether you would then go on to die or not. Obviously mortality was extremely high in this group of people anyway. And they did feel that even though there was discontinuation, the patients had received a reasonable duration of CPAP and they had met therapeutic pressures, so they had had a therapeutic intervention. And they go on to discuss, so okay, if there isn't a lot of benefit to patients for putting CPAP on, which is what this seems to show, then should we be doing it? I think that's, if it's badly tolerated, most widely regarded as being quite unpleasant, then really should we be doing that to patients and open up for some discussion?
I think that's a very good question.
Was there any mention of using kind of ward-based high flow?
It's not high flow, it's just wall oxygen, I think. It's not high flow oxygen.
Yeah,
and they also excluded patients who received CPAP for less than 12 hours, and also those patients who received inspiratory oxygen concentrations of less than 0.6 from the oxygen only group, just to see if that made any difference. I didn't really receive therapeutic CPAP and also weren't receiving high amounts of oxygen, and that didn't make any difference. There were still similar mortality rates.
It's quite a specific group, isn't it? If it's the ones that thought not to wouldn't benefit from invasive mechanical ventilation. So that's what we're asked for when we are asked for an opinion.
Yeah.
So the only difference seems to be whether you're going to get invasive ventilation or not. It's not whether you get ward treatment of whatever that might be, whether it's wall oxygen or CPAP or what.
Yeah.
It's actually the decision at the time of referral is potentially has more of an impact on their mortality, doesn't it?
Yeah.
Gives more responsibility on us, but anyway.
I just kind of, if we refer them now and say no, I think that's it.
A lot of the time.
Yeah.
Because
Well,
70% mortality is pretty high.
Yeah.
Really.
30-day mortality as well, so potentially they could have had a higher
yeah,
sort of, they didn't share that data.
And you don't know what state the ones that survive are in, and whether they go, most people that come into hospital will end up not back at their baseline. They'll end up at, if they were independent before, they'll end up needing carers, or if they were needing carers, they'll end up in a residential home or whatever.
Or what's happened to their frailty score.
Yeah.
For a long time, because their frailty score less than 6, so their actual frailty scores range was like 4 to 5 for the majority of patients, so a fairly homogeneous group.
I don't know, what did you think about the people that we'd said no to that you then happened to see on ACB or at the Glenfield later? After a week they were still on CPAP.
I mean, during this time I was at home on maternity leave, so I didn't see
anything. Well, that's true, you were. But
maybe some of the other people would like to say something.
So anyone still at Glenfield?
Does it depend as well on how the patient tolerates the mask and the CPAP? For some patients, it might be the relief of wearing a CPAP mask. Some patients hate it and they will just pull it off, but there will be that group that actually finds the constant pressure actually decrease the work of breathing, and there will be those who will be panting away, but they will still manage to eat and drink and be relatively happy. Looking shocking from the end of the bed, but if that's the limitation of care, so the patient controls should be definitely taken into the account.
Yeah,
I think we should ask the staff nurses actually about it, because that's what was happening, isn't it? We make the decision that the patient is not for intensive care, and there were those who were looking after them. Instead of having it for the acute care bed, it was essentially a CPAP ward in Leicester Infirmary, and they were dealing with everything what's related to that group of patients, despite the fact some of them with their frailty score sometimes higher than 6, and essentially still being put on the CPAP mask. So it would be quite interesting to find out from them, how do they feel and what's their observation?
I think from talking to them, from being the DART consultant, they've often found it quite upsetting that patients were still on CPAP a week, 10 days later, and they were clearly going to die, but nobody would take the CPAP off and let them die. And they did find that quite upsetting. That was a significant difference between the Royal and the Glenfield, because at the Royal we didn't really feel that the ACB had capacity and enough expertise necessarily to look at. So we would admit the ones that we would intubate, even if they were only requiring CPAP through both waves. Whereas at Glenfield they ended up leaving them with the respiratory guys because they're well used to dealing with non-invasive ventilation, and then they ended up doing daily ward rounds on the CPAP ward at Glenfield, and would bring them over to the ITU only when they needed intubating.
Well, from my experience,
it was different, but
a bit similar. When I was in Glenfield, the DART nurses were heavily involved still. The CPAP patients, but yes, that's the feedback I got from the DART nurses when they were just coming around just for the handover or just for a chat, that they were really upset about the situation.
Yeah, I think they were too.
I think with these findings, just kind of slightly more pragmatic approach, where patient group therapy is practically palliative. So you
and it's really hard to hear. You might as well just come in here and shout through the door.
Oh.
I locked it to avoid disturbance. Ask a question.
Oh, was going to say, presumably this kind of supports a more pragmatic approach in this patient group, in whom, you know, if 80% of them are going to die, it's practically a palliative intervention, in which case you can just focus on patient comfort. So if, like Kaya said, if CPAP offers them some kind of relief and comfort, go for it. But if not, then, you know, you can take it off without you know, fear that you're actually going to worsen their outcome, because you know their outcome is going to be pretty much the same.
Yeah.
Yeah, I would agree completely. Do whatever the patient most feels is comfortable.
Yeah.
Because chances are that they're in the last days of their life anyway.
Yeah.
So, you know, if they feel they're getting tortured, why would you make that worse?
So I did have about half of them had palliative care input in this group. So and like trying to optimise their comfort during the time when they were on CPAP. So they do address that kind of stuff a little bit. But yes, it does seem like you're damned if you do and you're damned if you don't. So you might as well just do whatever the patient.
Yeah, I think that's really important. And Dr. Briggs has just said that there was quite a lot of moral distress on ITU when the patients died after they'd been on CPAP for a long time, because we'd all and the nursing staff have got to know the patients.
Yeah.
And palliating awake patients is something that we're not really used to doing on ITU necessarily. I know the Glenfield do with the ECMO patients, and some of them are awake, but we're not really used to doing it. And actually getting palliative care involved can be really useful.
I had a patient that deteriorated overnight on CPAP and died in COVID area. He subsequently withdrew the treatment, and I agree that was really, really upsetting experience. And they're absolutely right. We don't know how to do it. What are you doing? You know, do you just take the hood off, put some Optiflow and just ease off the symptoms? So you just keep that hood up from the simple things, especially when you have this overnight.
Yeah, I don't think that there's a correct answer, Kaya.
No, there's not.
I think it depends entirely on the patient. I don't know if you remember when we had a mum and a daughter on the unit last year. And the mum wanted to, she was dying and she wanted to take her CPAP mask off. So she did. And their daughter was sat next to her in the bed next door with her CPAP mask on.
That's actually quite dignifying death with the family member.
Yeah.
Actually,
Well, it was, yeah. But
involved. My example, we knew that the patient was deteriorating for days. We knew it's coming there, family not acknowledging, and unfortunately on my night shift he decided to make his mind up. And the family wasn't really still acknowledging that he's dying. And I think looking through, you know, in the middle of the night, looking at the CPAP bed on our COVID bay, in the middle of that, you've got a patient who's panting away so badly that his hood was missing because he didn't tolerate the mask. It's just, and you try to, you know, to balance everything. It is challenging. At least that patient, the first patient, as I said, had actually a really way to, you know, to say goodbye, and it is difficult. It's difficult for all of us.
Yeah, definitely. Apparently, Dr. Scott is looking at patients that have been on CPAP or Optiflow and have been declined for admission to ITU. So if anybody is interested and wants to look at that, then I would have a chat with him. I know he's on there today, but yeah, feel free. I'm sure he wouldn't mind and would appreciate any help. Thanks for stepping in at the background at the last minute, Fran.
No problem. Sorry there was no PowerPoint.
That's all right. It's nice to not have PowerPoint occasionally. Hopefully I've shared the QR code for feedback for people. Potentially. Next week, we're actually doing something slightly different. We're having joint ITU and obstetric teaching, because obstetric lot have have teaching at the same time. So we're having both at the same time. So joint critical care and maternity teaching, both ECMO, COVID, non-COVID, any maternal patients basically. So I will share the link. We're going to use the obstetric team link for everybody, so I will share that with you all. But it will be the same time, 2 o'clock next Friday. So hopefully that will be really interesting. Yeah, have a good weekend, everybody. Thanks for help for presenting.